So, into rate setting, and that's the period that we're in right now. Once you've been designated as a rural health clinic, ISDH notifies CMS, and then CMS notifies your MAC, and remember your MAC is your Medicare administrator that you're working with. And our MAC is NGS. We already use NGS for our Part A and B claims with the health system. You then prepare a projected cost report, and this was once again where we relied very heavily on the consultants. They already knew how to do this. They filed a projected cost report for November and December of 2009. So you're basically saying this is what it has cost us to run this clinic. And there, I'm simplifying here. They then look at that data, and then NGS sets a rate for us that is based on our cost. And so that is then going to become our encounter rate that we are going to then, going forward, be paid for every Medicare and Medicaid encounter that we have. So once they set the rate, they then send us a rate letter. NGS sends us a rate letter. I'm waiting on the receipt of that right now. And then we take that rate letter and then go out and negotiate for the same rate with our Medicaid, so EDS, MHS, and the Medicare replacement plans. Generally speaking, those entities will all then play ball with you as a rural health clinic and will pay you with your rural health rate. So once you've received your rate letter, as I said, you can now begin billing. The current maximum rate is right around $77. So once again, as I said, I'm simplifying here. There's a lot that goes into setting that rate. But the bottom line is once that rate is set, you are then reimbursed at 80% of that rate for each one of the encounters that you have. Following that, once you've got your designation, May 31st of every year, your actual cost report is due. So on May 31st of 2011, we will file an actual cost report for 2010 that shows actually what it cost us to run the clinic. And then you can have some reconciliation occurs and some adjustment to your rate if what you're showing was slightly different from what you projected. So the next steps for us is that, like I said, we're waiting on that rate letter, so we'll begin billing soon when we have that all set up, working with CPO on that right now. The things to remember about billing in rural health clinic is that what we now know as Part B claims that go on a 1500, they are going to go on a UBO4 to NGS, and we get one fee for each entire service. The other big difference is the patient pays a 20% coinsurance for Medicare patients of the entire fee. Right now, of course, they pay something like 10% of what is the allowed rate. So for patients, it's going to be a big change, and we're going to have to really inform our patients and be careful about that, because really what it means for them is that it's more out of pocket for them when they're coming to a rural health clinic. And that's part of how a rural health clinic is supported financially, is not just from the government, but from patients. We're going to have to also reevaluate our payer mix, because when a rural health clinic pays off, it is really by having a lot of Medicaid patients, because those are the ones, of course, that under the way things are now, we get a very low reimbursement, and we can potentially get a much higher reimbursement. So we really are going to want to find ways to drive our Medicaid population if we're going to make this worthwhile. And then ongoing compliance issues, of course, the quality assurance is something that we need to stay on top of throughout the year. We're going to have another meeting with a community member in August. Ongoing review of and adherence to policy and procedure, something that we need to keep doing, keep noting that in minutes of our meetings that that's what we're doing. We may be resurveyed annually, but I've learned that that's not always a sure thing. When I have talked to people in other rural health clinics, especially in other states, I talk to people in Texas. They haven't seen a surveyor in 7 years because their health department just can't do it. Indiana appears to be a little bit strict, so probably what we need to do is expect that we're going to be resurveyed every year, but then not be surprised when it doesn't happen. So, in summary, rural health clinic is a federal designation for primary care in health professional shortage areas. Reimbursement is based on cost, and it is one fee for each encounter. The patient pays 20% of the total fee. There are quality assurance, process improvement, and policy and procedure components which are mandatory, and if they don't see that, you're going to be in trouble. We can expect an annual survey by the health department, and Medicare billing for professional fees is on a UBO4. Medicaid billing continues on a 1500. As I said, I could do a whole other presentation on billing. It's quite complicated. So I decided not to roll that into this presentation. So thank you.